My name is Vered Stearns. I'm a medical oncologist at Hopkins, where I lead the Women Malignancies Group. And this is the fifth part of our Survive and Thrive 2021 Lunch and Learn series. And I thank you for joining us today. I would like to also thank my co-director, Dr. Karen Smith, and our planning committee, Jackie Bacon is our program coordinator. We have some amazing patient navigators and advocates who are listed here, have been very instrumental in creating this series with us. So what we're going to do today is, in just a moment, I will present to you Dr. Browley, who will speak to us for about 25 to 30 minutes. We are also very fortunate to be joined today by Ms. Monica Dillard, who will give a patient perspective. And then we'd like to have a brief live feedback survey. We're going to send just about 3 questions your way that hopefully you can answer. And we'll have a Q&A. We ask that you put your questions in the chat, and then one of the moderators will ask the questions when possible live during the chat. And others could try and answer it as well. So hopefully we'll get to most of your questions. As a reminder, you'll be muted during the webinar, and please do not hesitate to add a question whenever you're ready for it. We do remind you that we will send evaluation after the webinar, and if you can, please do respond, because we're using those evaluations to design new activities and receive additional funding for our activities. So with that, let me just introduce to you today our esteemed speaker, Dr. Browley. Dr. Browley is a professor of oncology at the Johns Hopkins University School of Medicine, where he's also the 39th Bloomberg Distinguished Professor. He also serves as Associate Director of Community Outreach and Engagement for the Kimmel Cancer Center. In his role, he directs community outreach programs for underserved populations throughout Maryland. We're really fortunate to have him join us about 2 years ago from the American Cancer Society and the Winship Cancer Institute in Emory. He's a member of the National Academy of Medicine and a recipient of the Marty Diabolov Award for Excellence in Public Health and Cancer Control. He leads a broad interdisciplinary research effort of cancer health disparities at Johns Hopkins, working to close the racial, economic, and social disparities in the prevention, detection, and treatment of cancer in the United States and world. These contributions have been enormous, and I'm proud to call him my colleague, and I thank him for joining us today. Thank you, Dr. Browley.
Thank you. It's wonderful to be here, and it's always wonderful to be able to talk to cancer survivors and lay audiences. I'm going to share my screen right now because you probably know doctors cannot talk without slides. And let's see. And let me switch the setting. Okay. Can you see my cursor moving now, Vered?
Yes, everything looks great. Okay. Thank you.
I'm a medical oncologist and an epidemiologist, and I've spent the last 30 years looking at cancer outcomes. And we're going to talk a great deal about breast cancer and disparities in outcomes in breast cancer. We're going to talk at more of a national focus. These are some of the things that I do in addition to being a professor in the School of Public Health and the School of Medicine at Johns Hopkins. I wrote a book a few years ago. I still have to disclose that I wrote the book, but this talk is not about that book at all. We're going to talk about breast cancer epidemiology, which is really looking at breast cancer in the population, looking at risk factors, looking at how treatment is done, looking at outcomes, and that's what we'll focus on over the next 20 minutes or so. First, in the US population, breast cancer is the second most common cause of cancer death among women. Lung cancer is number 1. I mention this because many people think breast cancer is number 1. It is the most commonly diagnosed cancer, but lung cancer is the largest killer, followed by breast, followed by colorectal, followed by pancreatic cancer. I'm going to give you a bunch of data about race. I want to start out by noting that race is a very broad category. It is a socio-political construct. It is not a biological construct. It is not appropriate to try to divide populations by race and think that you're dividing those populations by something that is biological. And unfortunately, a lot of medicine, it is used as a biological categorization, but it is not. In the United States, in 2020, about 279,000 women were diagnosed with breast cancer. I should say 279,000 people, because about 1,000 of them were men. About 33,840 of those diagnosed were Black females. About 43,000 or so died, of whom about 6,500 were Black women. And Black women are 12% of the US population and 15% of US breast cancer deaths. Now, the other thing I want to point out is there has been a 40% decline in the age-adjusted female death rate from breast cancer going from 1990 to 2016. And we're going to go back over and over on that issue, and we're going to look at it in a number of different ways, because that's when you can tell the real disparities. Using the socio-political categorization of Black versus white, the age at diagnosis for Blacks is a little bit younger than the age at diagnosis for whites. These are median, which means half of all women who are Black who are diagnosed with breast cancer are 58 or over, and half of all the white women who are diagnosed are 62 or over. Now, this is the median. There are, of course, women who are diagnosed in their 30s and 40s. Indeed, 1/3 of all women who are diagnosed with breast cancer in the United States are over the age of 70. When we look at risk of being diagnosed for Blacks versus whites and risk of dying, these are our numbers. Blacks are less likely to be diagnosed with breast cancer, but more likely to die from it. And in epidemiology, we're going to try to unpeel why some of this. Now, I told you I'd show you this in a number of ways. This is the trends. This is death rate per 100,000. And the way you read this is in 1977, there were about 33 breast cancer deaths for every 100,000 Black women, the blue line here. And in 1977, there are 33 breast cancer deaths for every 100,000 white women. The death rate, and epidemiologists hate absolute numbers. We like to use rates because they tell you a little bit about risk. The death rate for Black and white women in the 1970s, or the risk of death from breast cancer, was very similar. It's the exact same, as a matter of fact. It was only in 1981, when we started learning how to screen and treat the disease, that the death rates start to differ. And you can see the disparity in death rate is the difference between the blue and the orange line. And you'll note the disparity is wider today than it has ever been. So an important point when we talk about Black-white disparities in death rate from breast cancer, they didn't exist in the 70s, and they've only started existing when we started learning how to screen and treat. And the 40+% decline in death rate for white women is shown by this drop from 1990 to today. In 2018, the last year we have data, for every 100,000 white women, about 20 died from breast cancer. For every 100,000 Black women, about 28 died from breast cancer. And the difference between 28 and 20, the delta, as we say, that's the Black-white disparity. Now, below Black and white lines here, and starting in 1990, because of an executive order from Ronald Reagan in the mid-'80s, we started collecting data looking at Hispanics, which is in yellow here, and that's an ethnicity, not a race. Native Americans and Alaskan Natives, which are only 1% of the population, which is why there's this noise as we look across the screen here, and Asian Pacific Islanders, which is another racial category. The racial categories, by the way, are defined by the Office of Management and Budget for every census. Now, from 1981 to 2010, the Black-white disparity in death rate increased. That means that the delta got bigger and bigger. And from 2011 to 2018, the Black-white disparity has remained the same. Blacks have about a 39% higher risk of death or death rate compared to whites. Since 1990, Blacks have had a 23% decline in death rates, and whites have had a 42% decline. For all women in the United States as a whole, it's 40%. And again, we're going to talk a little bit more about that. You can see again from 1975 to 2018, the decline in death rate for whites in orange, the first a small rise, then a decline for Blacks. And you can see it's relatively flat for the other races and ethnicities in the United States. Now, while there's been a 40% decline in the United States as a whole, the decline has varied from 20% to 51% in states. We frequently think about Black-white disparities. Now I'm going to talk about Mississippi versus Massachusetts disparities. The United States was very homogeneous in the 1970s and 1980s, but something happened, the decline started occurring, and these purple states have had a 20 to 29% decline. These dark blue states have had a 44 to 51% decline. And one of the things that we need to think about in disparities literally is Mississippi versus Massachusetts. Why did Mississippi have a 20% decline, whereas Massachusetts had a 51% decline? By the way, if I were to show you a graph of colorectal cancer or lung cancer, you're going to see something very similar to this. The states in the South, and there is a political message here too, the states in the South do not do as well for healthcare. These are also the states that have not expanded Medicaid such that all people in their states can have access to healthcare. Now, there's some people who try to say Black breast cancer as if it's a different entity from whites. And I've already tried to get in your mindset that there is no such thing as categorization of disease biologically by race. Part of the argument for that is when we look at the Black-white disparity for the country, which I just showed you, there are 6 states in the United States where there's no Black-white disparity. They're the states that tend to have the lowest death rates of any state. Whites and Blacks enjoy that. Now, the Black-white rate is essentially equal in a 7th state, but it's West Virginia, which has one of the highest death rates for Blacks and whites in the country. Also, there are 11 states in the United States where white women have a higher risk of dying from breast cancer than Black women in Massachusetts. I keep harping on Massachusetts, and that's because Romney Care, which really the Affordable Care Act was, or Obamacare, was a plagiarism of Romney Care. Romney Care started in the early 2000s, and we already have data to show that it's preventing women from dying from breast cancer. Now, the Black-white death rate is, as I said, equal in 6 states. They are the states that have the lowest death rates. A substantial proportion of women with breast cancer do not get adequate surgery, chemotherapy, hormonal therapy, or radiation therapy. Treatment, there's something about their treatment that is less than optimal. When I say something about their treatment, sometimes it's just the dosing of the chemotherapy, especially when you deal with people who are heavier, and 60% of Black women, by the way, are obese in the United States. When you tend to cut back on chemotherapy dosage because of weight, sometimes hormonal therapy is not prescribed, or it's prescribed and the prescription is never filled. Sometimes radiation therapy is given, and it's given on older machines that are not able to produce the energies of newer machines, and that is a less than optimal treatment. And sometimes with surgery, the surgeon leaves a margin positive and doesn't identify it for further resection or radiation. Or sometimes, Mary Jo Lund was one of my trainees in 2008. She published this. 7.5% of Black women in metropolitan Atlanta treated for breast cancer in 2000 who were diagnosed with a localized curable breast cancer did not receive surgical removal of the tumor within the first year of diagnosis. So sometimes getting adequate care, they simply didn't get surgery at all. Now, sometimes they don't get surgery because it's not offered to them. More often it's offered to them and they walk away from it and refuse the therapy. But the end result is a curable disease was not cured. Breast cancer, the reality, socioeconomic status, the availability of care, as well as the ability to use that care is sometimes a problem. By the way, one of the ways that we started our career was looking at Black-white outcomes in similar populations. Black women who are either themselves military retirees or they're married to military retirees have much closer to white breast cancer death rates in the United States than they do to Black women's death rates in the United States. Again, an indication that socioeconomics is really important. And a very intensive effort that started in Chicago about now 18 years ago is now starting to show, and keep in mind, it's a lead time. You know, it's 10, 12 good hard years of work. Then you see the death rate starting to come down. And that's happening in Chicago. Another pet peeve of mine is a lot of people stress, get a mammogram, get a mammogram, get a mammogram. That is not the message we should be talking about. Number one, we should be encouraging women to get into a program of routine, high quality mammography. And I say that because sometimes, especially people who don't understand cancer, shoot themselves in the foot. By the way, I hate mammogram vans. Mammogram vans are a way of providing lower quality mammography, but satisfying someone that they got a mammogram. But it is by definition lower quality compared to a bricks and mortar mammogram facility. About 10% of the women who die from breast cancer annually, somewhere between 9.5% and 11.3%, die because they either did not get a mammogram or the mammogram was not read appropriately. I should say they were not in a mammogram program of routine mammography, or the mammogram was not read appropriately. About 20 to 27%, 2 to 3 times as many people die because they get inappropriate treatment or do not get appropriate treatment. And I can't stop politicians from their advertisements about get a mammogram and get them to start saying get appropriate treatment if diagnosed. 2 to 3 times more people die because they get inappropriate treatment or no treatment at all compared to the mammography problem. Now, there's lots of talk about triple negative disease, especially triple negative disease in Black women. I want to talk just a little bit about that, but I want to point out the Black-white treatment problem that we see is a problem among Black women with estrogen receptor positive disease not getting appropriate treatment. Triple negative disease is cancer that doesn't express the estrogen, progesterone, or HER2 receptors. Those are 3 receptors that we have drugs that allow us to treat them. About 24% of Black women and 12% of white women have triple negative disease at diagnosis. This is just a colorful thing from the American Cancer Society. You can see for triple negative disease over here, 24% of Black women, 12% of white women, and these are the other various types of breast cancer that one can have. Now, what causes triple negative disease? Well, we can say there are correlations. Obese women who get breast cancer are more likely to have triple negative disease. Women who interestingly had a high carbohydrate diet in childhood, which means that they gained weight faster and start menstruating earlier, if they get breast cancer, it's more likely to be triple negative. And there are the reproductive patterns, women who have lots of children and then don't breastfeed. Breastfeeding prevents triple negative disease, interestingly. There are a number of social deprivation studies in Europe and the United States. This is a word, big phrase for studies of poverty, that show that poverty somehow causes more virulent tumors. And it's due to diet and birthing patterns and so forth that go along with poverty. For example, poorer women in the United States and Europe are less likely to breastfeed when they have children compared to middle-class women. And there is this huge correlation again with body mass index and higher stage of presentation and triple negative disease. Now, when we look at Black women in the United States, the obesity epidemic has hit them harder than any other group. If you go all the way back to about 1970, about 15% of Black women were obese. Today, it's close to 60% of Black women are obese. It's about 35% or so of white women right now, 35 to 40%. When we talk about obese and overweight for Black women, this goes up to 80%. So the obesity problem has affected Black women more so than any other racial or ethnic group. Now, in summation, a substantial number of women of all races and income get less than optimal breast cancer care. This can be no screening or poor quality screening. And I cannot stress the fact that a lot of people say, get a mammogram, but they don't talk about the quality of the mammogram. Diagnostics can also be of poor quality or not given at all. I've already talked about not getting surgery or poor quality surgery. The radiation therapy beam is not aimed appropriately, or more likely, and this happens even in this area, there are hospitals or centers that have older radiation therapy equipment that some of the newer centers or some of the larger centers would never use that equipment. They would consider it dilapidated. And then the inappropriate dosing of chemotherapy or hormonal therapy. And it's really not racial minorities are less likely to get optimal care. It's racial minorities and the poor are less likely to get optimal care. There are cultural differences in acceptance of therapy, occasionally comorbid diseases like obesity or diabetes that make aggressive care less appropriate. Access is an issue, and I cannot overstress, we already know, it's not just you have to give the person insurance, you have to give them insurance and the ability to utilize that insurance. And of course, racism and socioeconomic status discrimination exists. This is my really second to last slide. I will tell you, when we look at socioeconomics, college-educated people do much better than non-college educated people. And we have data to show that the access to and utilization of care, from prevention or risk reduction all the way through appropriate screening to appropriate treatment, of the 600,000 people who die of cancer in the United States every year, we have good data to show that 132,000 of those deaths could have been prevented if we had simply applied all the things that we currently know, including prevention, which involves a lot of not smoking, by the way. And this is just the old Johns Hopkins Hospital. Thank you for tolerating me, and hopefully I can clear up any problems I created in the question and answer session.
Thank you, Dr. Burrell. This has been such a nice overview and so many reminders to us as health care providers, in addition to our participants today. I'm going to take a minute and ask my colleague Elizabeth Saylor to join and introduce our patient voice today, and then we'll take questions and answers. So please do put your questions in the chat, please.
Hi, everyone. It is my great pleasure to introduce Monica Dillard, who's here today to share her story. She is a young woman in her early 40s living with metastatic breast cancer. She's been thriving with MBC for over 6 years. She just recently completed a position as a cancer prevention and education coordinator for her sorority, which is the Maryland chapter of the national organization Zeta Phi Beta. And when she's not with us and sharing her story or doing advocacy work, she is an accomplished educator within the Baltimore County Public School System. She's actually an assistant principal at a local high school. So she's going to share her story about being a breast cancer thriver and how she's dealt with this challenge as a young woman and as a person of color. So Monica, you're up. Thank you so much.
Thank you, Elizabeth, for that wonderful introduction. And thank you for having me. So I'll try to make my story short and concise because it can be an intricate one. In 2014, at age 35, I just laying in bed, went to scratch under my arm and felt a palpable lump in my breast. I will admit I was not one who was mindful of doing monthly breast exams. I will openly admit that. So that was a Thursday. On a Monday, I got in to see my oncologist. I mean, not my oncologist, my gynecologist, excuse me. And I said, hey, you know, this is new to me. Can we check this? When I get there, it is, Monica, you're young. You're 30, about to be 35. You're good. This is a cyst. Feels like a cyst, probably have dense breasts. You're okay. Now, my gynecologist is someone who also performed a myomectomy in which I had fibroids removed in 4 years earlier. So I felt comfortable with this person, opened me up, did surgery, had never steered me wrong before. So I went with it. For 3 months later in April was my annual exam. Brought it up again just to make sure, because again, that first time I was not recommended any type of imaging, no mammogram, no ultrasound, nothing, you're fine. So in April, I bring it up again, just double checking. We're still sure that there's nothing going on. Same story, Monica, it's probably a cyst, you have dense breast, you're young, you're fine. So for the rest of 2014, I lived like I was fine. Fast forward to 2015, the day after my 36th birthday, was my annual exam. And maybe a week prior, I noticed that the lump had started getting bigger and it started to get painful. So I went in for my regular exam and I said, hey, let's check the breast. He checks the breast, stops there and is like, what is this? So I had an outer body experience. I'm not going to lie to you. I'm like, what do you mean? What is this? I came a year and 4 months prior to bring this to your attention. And I was told it was just a cyst. I have dense breasts. Don't worry about it. So I immediately was sent to have a mammogram ultrasound. That didn't come back well. So next was the core needle biopsy. And I will never forget, it was the Wednesday after the Freddie Gray riots. That's when I got the dreaded call and it was not a nice bedside manner of a call. I was at work, wasn't asked to sit down, wasn't asked to come into the office. It was, did a radiologist call you? Nope. Well, you have cancer. And my life changed after that. The first hospital system that I was with outside of Johns Hopkins, once this all started, I met with a breast surgeon, never would have recommended for me to have a PET scan, knowing that I sat for a year and 4 months without a diagnosis. She said, nope, I'm going to stage you at stage 2. We're not going to get you a PET scan. Insurance companies don't really like to pay for them. So no, we're not going to do that. Just didn't really feel comfortable with that. So did not go with that breast, with that particular health system. So then when I transitioned to the next, I was given an oncologist, and she said, you know what, I'm going to get you that PET scan. I really, a year and 4 months is a long time to not know what's happening in between. So started off stage 2, got that PET scan, and it revealed that I had 2 small two small lesions on my liver, that the cancer had metastasized. So that is my story, short story in a nutshell. Definitely felt misguided. I was hurt. I blamed myself a lot. I'm not gonna lie, sorry. But moving forward, that's my biggest piece of advocacy work, is making sure that women are advocating, they're following their gut, and they're asking questions, and that they're demanding that they be imaged. So thank you.
If I can just add to what you just said, I would not bash myself too much about not doing breast self-exam, because I literally have no study to show that monthly breast self-examination saves lives or is beneficial. I have studies to show that being aware of one's breast, and if you feel something in the shower or otherwise, and going to the doctor, that does help. But for years in the 1950s and 60s, doctors encouraged women to do monthly breast self-exam. That started to wane in the 1990s, although we still hear about it, but there's no evidence that it would have helped you.
Thanks. Sorry, usually I'm not emotional 6 years in. I can tell the story easily, but it just got me today. So sorry about this, guys.
Thank you so much for sharing your story. And it is a common story for young women in general. And I wonder if, did at any point early on listening to Dr. Browley's presentation, did you feel that being a Black woman has affected the care you've received? If you don't mind sharing your thoughts.
Yeah, part of it did. And he talked about being college educated, and, you know, I know that the different, I guess, parameters of Black women who don't get great care. Like, I'm college educated, I have a job, I have good insurance. So I'm like, well, I check off all of those. But then I also felt like it was age, you know, you're young, can't be it. So that's not what it is. And he just said half of, you know, women who are diagnosed Black or white are in this age range. So I fit the age range of the half that was in that 30 plus. Yeah, I do. Part of me feels like I do.
Thank you. We have a couple of questions, if I may, for both of you. One of our participants is asking, what recommendation do you have for a survivor? How can the community support women with less access to optimal care?
Fix the political system so that they can get optimal care, and stop accepting the fact that there's a large number of people who get really poor care. Matter of fact, in Maryland, we're in fairly good shape in Maryland because anybody can get some type of health insurance. But you know, people who live in the southern states, people who live in the states that have not expanded the Affordable Care Act, there's a whole bunch of them who know they have something in their breast and they just walk around and cannot access care.
So how can others support the community?
Honestly, for me, because it's personal for me, it's a mission. You know, being a part of things like this, hearing stories, encouraging, not just in the month of October because it's breast cancer, you know, awareness month. I'll be honest, I don't have a history. I don't have a genetic history. I had genetic testing done. There was no, you know, genetic reason that this occurred to me. So I knew breast cancer, I knew about it, but I didn't know like I know now. And yeah, I feel like it's our job to make sure that, you know, we are educated, especially women, because a lot of people think it's genetic, like it gets passed down genetic, and that is not the case. So we walk around thinking, oh, well, you know, no one in my family has it, so I'm good, so I don't need to worry about it. And not that was my mentality, but it wasn't hitting me like smack dead in the face. So I didn't educate myself to know anything about it. So I feel like we have to be open and willing to, number one, educate ourselves. And then as women, we have to educate each other. And it's just not a women's disease. I mean, men also are affected by breast cancer, but just because it's not smacking us in the face and it's not affecting our family or our immediate or ourselves immediately doesn't mean that it can't happen.
85 to 90% of women with breast cancer have no family history of breast cancer. You know, you can flip that around, 10 to 15% do, but the overwhelming majority do not.
Let me, there's a comment and a question, or Elizabeth, do you want to ask a question?
Yeah, so I was actually gonna, I was going to note one of the, well, first of all, Monica, I wanted to say thank you for sharing your story. And we've gotten a lot of comments about how meaningful it is to the participants on this webinar to hear your story. And one of them referred to it as a sacred story, which it truly is. So thank you so much. And the other, there's a comment or a question about how do we, as women, maybe younger women who haven't had a lot of time to advocate for ourselves, or older women who, you know, are not always treated as well by the healthcare system, but how do we recognize providers who maybe aren't the best providers, even in Baltimore, where we have tons of wonderful hospitals? How do we, sometimes it's a gut feeling, sometimes it's how do you know your surgeon is the right person to be doing the best work? So I think that's a question for all of you, for you, Monica, from a patient perspective, and Dr. Browley and Dr. Stearns as a practicing medical oncologist. So
I'll just piggyback on that and just ask our medical professionals. That's a great question. Like, is there a standard of care that's supposed to be afforded? Because that's what I questioned in my whole experience. I feel like a standard of care, like a ball was dropped at some point when I was never even offered imaging from my first visit, a year and 4 months prior to my diagnosis.
Yeah, well, I don't know if I would have imaged you as much as I would have biopsied the mass.
Okay.
I would have gotten a mammogram just to make sure there were no other masses, but I think the problem for you was that you didn't get the biopsy or removal of that dominant mass. Now, there are breast cysts that come up, and it's even appropriate in my mind to watch the cysts for a short amount of time, but I would not have watched it for more than 2 or 3 months before I had gotten a pathologist to look at a piece of that. That's in my opinion, you know, I can't give you formal advice, but that's how I would handle such a thing. The other issue that I see in the chat, there's questions about mammography. The current recommendations are that women age 45 and above get mammography every 1 to 2 years. There are no studies to show that every year is definitively better than every 2 years. There's actually some long-term studies that suggest that every year might increase the radiation dosage and be harmful, more harmful than every other year. So every 1 to 2 years, buyer's choice, patient's choice. Insurances will pay for every year among women who want every year. There was a question about someone suggested that insurances would only pay for every 3 years. No, they will pay for every year. The recommendation is women age 45 to 74 get mammography every 1 to 2 years. There are many women who choose to get it every year in their mid 40s and early 50s and then go to every 2 years. That's reasonable as well. If a woman has a family history of breast cancer, now this is, Monica, this doesn't help you, then she should talk to preferably a doctor who does a lot of breast cancer and figure out if they should get mammography screening for women in their 30s or ultrasound screening for women in their 30s. One of the problems with mammography in younger women is it's very hard to see a tumor. It's very hard to read a mammogram in a younger woman. The question, how do you know that you've got a good mammographer? I would go to a breast center. My problem with those mammogram vans, I know there's a whole bunch of folks who think they're doing wonderful stuff with mammogram vans. A good mammogram involves the mammographer, a radiologist who reads mammograms, looking at last year's mammogram and the mammogram from the year before and looking for trends and changes over time. My problem with those mammogram vans is they rarely have last year's mammogram to look at as a reference. So that's why it is giving lower quality by definition. Bricks and mortar facilities, a mammogram should be read in my mind by a mammographer, not a radiologist who does a broken leg before and a brain tumor CT scan after reading the patient's mammogram. You know, mammographers read usually 50 to 60 mammograms per day, and you find them in women's centers and breast centers. Frequently, when you get a mammogram at a breast center, you will even meet the doctor who's doing the mammogram, not just the technician who's doing the mammogram. I don't know, Vera, you want to add to that?
Yeah, no, I agree completely. Trying to ideally go to a consistent place, a place that has a high volume and, you know, the machines and the technicians and the experience is there. And related to that, you know, one of the questions in the chat, how do we avoid poor care? And Monica, you told your story. I mean, you trusted this physician, and what I tell patients and family members is don't be afraid. You're not hurting anybody's feelings here. You advocating for yourself. So if you feel something and it doesn't seem right, and you go to your doctor and you don't feel, you're not satisfied with the answer, seek another physician. And how do you find, you know, you want a system that provides multidisciplinary, high quality care, and don't be afraid of asking for another opinion. I encourage my patients to get a second opinion if they wish, and we're here for whoever wants to be treated by us. So as a consumer, you have a right to request another physician to see you, and don't be worried about hurting anybody's feelings.
Insurances will pay for second opinions as well.
Absolutely. And as a rule of thumb, I tell individuals, I think, you know, especially when you hear the word cancer or being diagnosed, or there's something on my mammogram, people become anxious and they want something to happen immediately. But in my opinion, it's okay to take just a little bit of time, a few days, a couple of weeks to get the right information, to make sure you have a plan you're comfortable with, and rather than follow the first opinion that says you need to have surgery immediately or you need to have X, Y, and Z done immediately. Again, as a consumer, you have lots of rights, and there's the ability, especially in our Baltimore, Maryland community, to seek high value quality care. Dr. Bradley, one of the questions is whether there are specific treatment to perhaps Black women that you might be aware of.
Yeah, there should not be. Equal treatment yields equal outcome amongst people. If you look at Black-white outcomes in the United States, Black women do worse. If you look at Black-white outcomes in specific hospitals, I first did this 25 years ago at the old Bethesda Naval Hospital. Black women and white women do equal at the Bethesda Naval Hospital. It's the same true at Hopkins. There are a couple of drug companies now that are out there advertising that they have Black women-specific trials. I would be careful of that. But the problem is not that Black women need a different treatment. The problem is Black women need a treatment. Keep in mind, I showed data to show that 7.5% of Black women in Atlanta, Georgia in the year 2000 did not get surgery for a curable breast tumor. All right. Now, I'll tell you part of the problem with that is, many of these women were offered the operation. The majority were offered the operation and walked away from it. Now, there's very little incentive in healthcare systems to beg patients to come back when the patients don't want to be treated. A lot of there are even studies on why do these women refuse therapy. There's a number of good studies. Some of it is, I can't believe that I have cancer. I just can't believe it. I don't trust them. Why me? Some of them is one of a very famous series of a very famous paper diagnosed with cancer and get treated. When Aunt Sally told the family at the family reunion that she had breast cancer, they gave her food on a paper plate because nobody wanted to catch breast cancer. And I don't want to be ostracized like that, so I'm not going to get treated for breast cancer. I can't take time off of work. Who's going to take care of my kids? These are all reasons why people don't get adequate care that can save their lives. And then the insurance issue is another, who's going to pay for it? And in Maryland, we still have people who don't get treated because they don't have transportation to the doctor or to the hospital.
So I'd like to chime in as a navigator. I think this is a big part of my role. And I want to sort of ask a little bit about equitable care. So there's equal care, and then there's really more equitable care. So I'm curious about your thoughts on sort of assessing some of those barriers, whether they're long held kind of family beliefs about breast cancer, whether it's a patient is told she has breast cancer and she's never really known anyone to survive cancer. They've all died, so what's the point? Or I don't know how I'm going to be able to handle work. How do we, in the process of sharing a diagnosis with someone, how do we make a presentation that sort of either allows for the patient to share those fears, or that we sort of upfront or kind of proactively saying, we're going to guess that maybe some of these things are rolling around in your mind and we're here to help you with those things?
Well, a lot of places don't have the resources to hire social workers and navigators and other things. The insurances will pay for the patient to see me or Vered. The insurances will not pay for the navigator, will not pay even for the social worker. Those are add-ons that the clinical center that the woman is going to has to pay. We're fortunate at Hopkins. I don't want to say that we're awash in money, that we can afford these sorts of things, but you can go to really good doctors in really good places, not very far from Hopkins, where they simply don't have the extra add-ons, which is really unfortunate. There's a lot more to treating a patient than just prescribing them a drug or cutting a tumor out or aiming a radiation beam. And it's unfortunate that the social needs are oftentimes not met.
Yeah, I guess my question is, how do we get, and this is a huge policy question, but also at each institution, how do we start to see those things as, I guess, comorbidities? Or, you wouldn't treat someone necessarily if their diabetes were out of control until you got that under control. So how do we move our, I'm guessing, I know that you may not have an answer for this, but how do we sort of move our healthcare system and our society, even if it's just within the state of Maryland, to recognize those things?
Well, I spend a lot of my time trying to work on what we call risk reduction. You used to call it prevention. And we call it risk reduction now because it's a much more appropriate term. When we talk about prevention, I've had someone who's reminds me a great deal of Monica say, "You're accusing me of failing prevention or not practicing prevention." When you say risk reduction, it's very clear that some people, you're not going to reduce everything to zero. So some people are still going to get cancer, even though they stayed thin, they exercised, they did all the right things, but they still got cancer. That unfortunately happens, and it happens a lot. And so we don't want those people thinking, what did I do to cause this? So I want to focus a great deal on diet and exercise. And by the way, my risk reduction reduces risk of breast cancer, colon cancer, lung cancer, prostate cancer. We're not getting into disease Olympics where we focus only on one disease. It's 5 to 9 servings of fruits and vegetables a day. It's walking around the block every day to get a little bit of exercise. It's not smoking. It's trying to maintain an ideal body weight. And Verit will tell you, I struggle with that one. And it's trying to struggle to do all of these good things. And then if you do get sick, you at least optimize the chances that we're going to be able to treat it. And by the way, the things I just talked about, the 5 to 9 servings of fruits and vegetables, the exercise, the ideal body weight, the not smoking, it prevents cancer, it prevents diabetes, it prevents cardiovascular disease. And it even reduces the risk that you're going to need a knee or hip replacement later in life.
I'm going to wrap up in just a moment. I want to finish the conversation, but I'm going to ask Jackie. She was going to send just a few server questions, if you guys don't mind the participants answering. Yeah, I think just to kind of go back to some of the lifestyle modification that Dr. Browley described, it's a family affair. It's something you should do with your loved one, with your family, with your friends. It's good for all of us to prevent and minimize comorbidities of the disease and toxicities. So it's something that we all should be doing and thinking about. Jackie, do you want to put on the questions quickly?
Yeah.
The CDC. And we thank you for joining and providing feedback. We had a short survey, of course, just a moment ago, but in addition, we will send another evaluation. And please, if you are able to take a few minutes and help respond, it will guide us as we plan additional programs for 2022. And a reminder, we have one final webinar for this 2021 series, and it's sexual health after breast cancer diagnosis. And it will be by Dr. Sharon Bober, and this will be on Wednesday, November 17th from 12 to 1. And again, thank you so much for joining us today. And this has been recorded and will be shared on our website.